Welcome to the Java Cafe, Java fam. Good morning. Welcome to the Java Cafe, Java fam.
Good morning, everybody. Good morning. Good morning. For those of you that were with us in the 8 o'clock hour, we are back at 9 a.m. As I said before, we are looking at the 8 o'clock hour, switching around due to folks being back at work and not being as available to watch and get the information that we share generally in the Java Cafe. But we are keeping, for now, the 9 a.m. hour for your healthy Java on every first and third Tuesday here in the Java Cafe, which is sponsored by the Massachusetts General Hospital Office of Equity and Community Health. Today we have, and we're celebrating and acknowledging Pride Month, and we've talked in the Java Cafe with a man who said he has trans experience. We've often talked with Quincy Roberts, who is a member of the Java fam and often lifted issues around violence with trans women and things like that. But one of the things that is very important, we had Dr. Robbie with us a couple of months ago talking about his clinic that provides services to trans men and trans women. And so this is not a new space for us. We have a wonderful doctor with us today who identifies as she and them, and where she's comfortable, she can explain that, because we've also been very sensitive about naming pronouns as well when we talk in this space. But they are here to talk with us about health equity in the LGBTQ plus community. And so when Dr. Alabre, Cindy Diggs, who's, like an associate producer, talked about this subject, Dr. Alabre reached out to Dr. Williams, who is of Fenway Health, not with Mass General, but just shows the wonderful collaboration between our health provider entities here in Boston. But I'm going to bring both of them into the room right now. And so we can get ready to chat with them. First, our Dr. Williams, and they will introduce themselves in a couple of seconds. But Dr. Alabre, good morning.
Good morning.
Good to see you. How are you? I don't think when we were on, I'll say Happy Pride. Were we on in June? Or what's today? We were on in June 2 weeks ago, right?
Yeah, 2 weeks ago.
Okay, I'm still kind of
No worries.
Maybe the Java impact is slipping. But how are you? Happy belated Father's Day to you.
Thank you. I appreciate it.
You all go in and say Happy Father's Day to Dr. Alabre. But Dr. Alabre, when we talked about this subject, why was it important? I know why it's important for me, but why was it important for you to make sure that we talk about this specifically for the LGBTQ plus community?
Lots of reasons. Obviously, we try to do a lot, but you can't do it all at once. So we sort of tend to take opportunities when it comes in terms of celebrations, months, and whatnot. So for Pride Month, that was somewhat obvious that we would obviously address this. But there's also obviously a lot of inequities, as you've mentioned, in healthcare when it comes to LGBTQ. There are some particularities as well when it comes to taking care of LGBTQ plus community members that we don't always acknowledge or understand or know about. As we try to do every day here when we have the shows, to sort of bring awareness to everyone about what's out there, what's available, resources, and how to best care for themselves. And this is obviously one of these other areas where we really want to bring awareness and make sure no one's left out.
That is a perfect way to end it. And I saw Dr. Williams kind of smile at that. And so without further ado, or Dr. Alabre, if you want to have the pleasure of introducing Dr. Williams, I will just share with you that Dr. Williams is a primary care physician and resident preceptor, and which means that she precepts those that are coming in for training at Fenway Health. She does curriculum development and is a fellow. Does curriculum development, is a curriculum development fellow and sexual and gender minority health initiative, and from the wonderful HMS, faculty co-director of the Advancing Excellence in Transgender Health National Continuing Education Conference inaugural 2022 Train the Trainer course for all healthcare professionals, sponsored by the Fenway Institute and Harvard Medical School. And so we just want to name that as part of your credentials. But Dr. Larber, you can give whatever impression that you have of Dr. Williams, because we're all just meeting. And so how did we land with wonderful Dr. Williams? And then we'll turn it over to her to introduce herself.
Sure, I think you got a good background there. And the most I'd like to say is how willing Dr. Williams was to be here today and to participate and help. When I reached out to her, we had not met, and I had actually not heard of her until I sort of started reaching out to find people in the Black and Brown community who could do this, because again, we try to have a little bit of representation and bringing awareness to health equities and the lived experiences and everything else. And so she was highly recommended by some of my colleagues. And when I reached out, it was a no-brainer. She wanted to be here and did everything she could. So I'll stop there and let her introduce herself a little more.
Cool. Well, thank you to the two of you for inviting me into the space and doing what you had to do to make sure that I was able to get here. I really appreciate it. You know, I'm not the easiest person to catch a hold of by nature of the work that I do, but I really do appreciate it. I am Dr. Keisha, or Dr. Cool, as some folks call me. I identify as a queer and trans person of color, and what that means to me, because it can mean many different things to different people, and I want to make sure that we understand that. I am queer and that I am my own person. I don't fit into any boxes, and I identify as a person of trans experience. If we're talking about gender, I was assigned female at birth, but identify as gender non-binary, though I use the term trans-masculine of center. So most of my comfort is more, if you're looking at a spectrum of gender presentation, is on the masculine form of the spectrum in terms of my hair, the way that I dress, my voice, the way that I carry myself, my mannerisms, and so be it. So those are, in terms of my gender and sexuality identity, those are the important terms there. And of course, proud person of color. Happy belated Juneteenth for the folks in the community. And I'm just excited to be here and to be doing the work that I'm doing. You heard some of my credentials with Jimmy, so I won't rehash those again, but a lot of my days, if you look at my typical work day, is spent doing primary care at Fenway Health, where I am fortunate to be able to do primary care as a family medicine trained physician. So I run the spectrum of age there. But also what Fenway affords me to do is to be at the forefront for folks that are in the community that identify in any spectrum in terms of sexuality or in terms of gender or biology, to feel comfort in coming to Fenway and knowing that there are people there that are able to take care of them and to deliver, important to me, high quality healthcare, because everybody deserves that. That's what got me into medicine first as a person of color, and seeing the things that my family experienced in South Carolina, which is where I grew up, and even more so as the queer person that I am and holding this space, and the power that comes along with being a doctor, right? See, other stuff that I do throughout the week. So the fellowship was a huge opportunity for me. My background is in education, believe it or not. I spent the first, I want to say 30 to be exact, years of my life doing education, anywhere from early childhood, like K through 12, doing tutoring to youth who are underrepresented in professional careers and secondary education. At the high school level, I did some um, professor work, so teaching biology, anatomy, physiology, and that type of thing at the university level. And then decided that I wanted to go back to school. So, so yeah, that's what brought me to medicine. And so, like all of these things that I'm passionate about are what drives me. And there's a place for it, and there's a need for it. And so that's my duty when I wake up every day, is to show up the best person that I can be, true to myself and authentic to myself, and those things that are important to me, and to do that in the face of whatever obstacles happen to be in the way. So yeah.
Thank you, Dr. Labre. Go ahead.
Oh no, that was just amazing. Hearing the background and where you've been and and I was thinking how perfect you are for this sort of health education segment, because this is what we do, try to educate, and knowledge is power, as I've said a few times here, and so we definitely appreciate all you've done and all you're doing. And let's hear more about this.
There's definitely, and so Dr. Now, is it Kesha or Keisha? Which
It's Keisha. It's Keisha.
Okay.
Yeah.
Keisha, there's this thing that Dr. Alabre and I have where he knows when I'm about to go a little rogue, because I'll hear something and it gets the activist in me stirred up. And so there is high potential today for that to happen, because in listening with you and how you present and everything, there is so even in the presentation you just made, there's just so much to unpack there. And so I think you ended with the obstacles. And let's just name that when we're talking about LGBTQ plus issues, and then being a Black, as you said, assigned a woman, one of the things, I'll be perfectly honest with you, that amazed me was when you identify, as you have on the screen here, they and she, and then in the explanation say that you identify as center of masculine. And so that goes back to the thing about not being in any box. And so I just want to name a respect or whatever for that, because it was first time I saw the pronoun sort of mixed, if you will. And so definitely acknowledging that. But with all of that, and you said the obstacles, when you hear of the term health equity for the LGBTQ plus community, how would you describe that with one word, and then give us the context?
How would I describe health equity with one word?
Yep. Yeah. I know you're an educator, and so you could do a whole
wow.
Yes.
Moratorium. One word is hard. One word is hard.
We could go with
limited. Okay, limited, and I'll say yet expansive. I'll say that.
So give us now you can do the dissertation. Give us the context. You say limited and expansive. And so in that, where are we with healthcare and equity within the LGBTQ plus community?
We're making progress. I will say that. And I say that acknowledging the fact that the world, the nation has been kind of a whirlwind, a tornado for my brothers and sisters and folks of siblings of trans experience over the past year. Before that, we were making progress, and we've just taken a couple steps back.
Okay.
But the fact of the matter is, so I'm a family medicine doctor because I believe that everyone should have access to primary care and preventative health measures. That is a human right. The fact of the matter is, coming through medical education training, it's not integrated into the training that we receive and the education that we receive. So what's happening is a lot of my colleagues, as well as myself, are coming out of school and residency training programs not equipped to accurately care for this population. Not saying that their humanity is any different than any heterosexual person. We're all human. It's just the fact that when we as kind of type A people want to be perfect at what we do, or else we don't want to do it. And that there's the problem. When you don't get the training and the experience in caring for a community, you come out and say, I don't know if I can do this. So if I can't do it my best, I don't want to do it. Or I don't want to feel like I don't know anything. So I'm just gonna not pay any attention to that. I'm gonna stay away from it. And so that leaves us with gaps in access to care, where folks can feel comfortable knowing that they're seeing a provider and knows that this provider is equipped to take care of their health as a human being, but also feeling comfort, psychological safety, that they're not going to walk into that space and feel alienated and turned away. And so I say limited in the sense that we don't have the workforce that's equipped to take care of the population the way that we should.
Yep.
And also limited in the sense that folks don't feel comfortable accessing the care that they should be able to access.
Now that's in a general sense. Let's talk about being Black and brown even more.
Oh yeah.
So let's go there and you know,
oh yeah,
those moments. Let's go there and talk about the fact that in general, those are issues. And then if you're Black and brown, and on anywhere of what some may refer to, you know, on the spectrum, how more so is it limited? Is it just as expansive in specifically talking about Black and brown?
All right. So I'll frame this with two things. One, the idea of intersectionality with Kimberly Crenshaw. And I'll couple that with a theory known as the minority stress theory. The minority stress theory basically entails that folks are, they encounter stressors in their daily life. This can be external stressors or internal stressors. And these stressors are unique to a person based on their identities or how they exist in the world. So if we take the stressors that are experienced by a person of a sexual and gender minority identity that are unique to that identity, and then you tack on that the stressors that come from being a person of color, they don't come one at a time. You don't show up one identity at a time. You show up as your entire self.
And let's also name the fact that you said as assigned, then appearing as a female. So there's and in medicine. So go ahead. I'm sorry.
No, yeah, exactly that. And so the minority stress theory was initially just brought about in terms to conceptualize the way that stressors internal, so that the internalized stigma and the internalized phobias that folks have from their specific identities that are learned from society, as well as the external or distal stressors. So those that are occurring because of who they are in the society, whether it's homelessness because of socioeconomic status, whether it's homelessness maybe because, you know, I'm a Black person that grew up in the South in a very religious home, grew up Baptist, and so those stressors that are put on by religion, those stressors that are put on by limitations. Oh, I was assigned female at birth, and so I shouldn't be able to do this, or this should be for a man. You know, you take those effects of those emotional and mental and psychological effects of those, and those things lead to actual physical manifestations in the body that affect health and health outcomes.
So it is real, because a lot of people don't believe this, and I might get in trouble while saying it, but stress does. I saw somebody post the other day that body remembers everything. So let's once again just name the fact that stress does display itself in the body, and in this case, it's the intersectionality, as you said, of in this case all four spaces in which you show up.
Exactly. And when you talk about stress and affecting the body, when you're stressed, your body releases high levels of cortisol. And if you want to go into the biology of what cortisol does, and I'll talk about from the perspective of a person of color, but this applies to anyone who is stressed. Chronic stress, and you wonder why folks have, high rates of high blood pressure, high rates of heart disease, in those stressors. What do people do to offload those stressors? Maybe they want to consume alcohol to help kind of bring themselves down. Maybe they want to smoke cigarettes or participate with nicotine in order to relieve those stressors, or they may seek self-medication through other substances to help relieve those
Or
stressors.
other acts and behaviors. Yep.
Yeah, exactly. And so these behaviors, again, compound the effects, the physical effects. Not only just cortisol plays in the body, but also the way that folks, the habits or the behaviors that are result from those stressors or result from trying to deal with those stressors. All these things compound to affect how we are able to experience health. And so, when I was in med school, folks talked about the biopsychosocial aspect of medicine. So encompassing all the pieces that come together to affect somebody, a person, or their health. This is just another way of presenting and thinking about that. But we have to be able to think about all of that when we're sitting in the office with somebody. It's not just their diabetes that they're concerned about. It's not just their heart disease that you're concerned about. It's not just their mental health that you're concerned about. You got to be concerned about all of that, because if you're not interacting with that entire person, the trust is gone.
Yeah.
And this is getting into my kind of soapbox about being providers, the system in which we provide care and the limitations there. But we had to slow down. Rest is resistance. I'll say that too.
Yeah.
But we got to slow down in order to be able to adequately provide care that everyone needs and everyone deserves.
Absolutely. Dr. Labre, I wanted to give you a chance because, I can easily jump in.
Sure, no, there's a lot there. I was thinking, where do we start? To sort of break it down a little bit. I wanted to hear a little bit about your experience at Fenway Health. And I don't know if you've had experiences at other clinic settings, where maybe it was not so welcoming or understanding. And how do you contrast those experiences, if you will?
Yeah. So full disclosure, I am 2 years out of residency now.
That's all?
Yeah. So that is all.
You present as a long time attending, but go ahead.
I age very well. So but for context, I went to medical school in South Carolina, so those clinical experiences there. I trained residency at Cambridge Health Alliance, so CHA, the Tufts program, and then my 2 years here at Fenway. Those are, in terms of clinical context, those are the contexts that I had, and vastly different, different aspects there. So in South Carolina, and sharing a little bit of my story in this, I identified as queer, but in terms of being comfortable with my gender and who I was in the world, I was not. I had fears about patients not wanting to interact with me. I had fears about my grades or my progress in school being negatively impacted because of who I was. I was in Connecticut in the Northeast before going to med school. So I did grad school and the teaching there. And so when I went back to South Carolina, I actually kind of went back in the closet a little bit, so to speak. So where I was dressing as I was before med school, as I am now, I had essentially two closets when I went to med school. I had the clothes that I wore to school. Yeah. And then also the clothes that I wore, when I was just out and about or to see my family, that kind of thing. So definitely not comfortable there. I didn't feel like I had a mentor or any faculty in that sense that I could be comfortable being my full self with. So when I was anything that your advisor or mentor could advise you on, I had no comfort there. And so a lot of this stuff was spent me trying to figure things out on my own. And so when I applied to residency, my girlfriend at the time, who then became my fiance and is now my wife, who is also within the MGH system, the HMS system, was like, we're like, look, we gotta go back somewhere I'm comfortable. And she was able to find this. She actually found the residency program that I ended up applying to and loving. So at CHA, it was vastly different. They say we welcome all, and they mean that. And also, there was a significant growth edge in order to be able to provide competent care to members of the LGBTQ community. Some of the things, like for instance, at Fenway, we talk about being free sexually. It doesn't matter what you do in the four walls of your bedroom. I'm not here to judge you for that. I'm here for you to be able to say, hey, Doc, this is what I did. This is what I got going on. And can you help me? Is there something I should be worried about? Right. That's all I'm here to do. Live your life. And that's the way it should be. And so Fenway provides that comfort. That comfort was at CHA. I personally can't say that I had noticed that comfort when I was in South Carolina.
Okay.
The knowledge base to be able to answer those questions and to actually help this person with their concerns, the knowledge is there at Fenway. We were learning the knowledge at CHA. I don't remember that conversation happening anywhere in South Carolina much. So that's where, besides in the classroom, but that's where we are. If that makes sense. Does that answer your question?
It does. I also wanted to sort of follow that up with, can you speak a little bit to sort of the aspects of health when it comes to LGBTQ that are different? What should someone listening today be aware of when it comes to getting their care, and what is so different, if any, about how that should be provided?
The only real difference at the root is being linguistically appropriate when you care for folks that are within the community. Otherwise, again, we're all human and we all share the same concerns. Just because someone identifies as queer or trans or gay or lesbian, we automatically are like trained socially to associate certain behaviors with the community. But the reality is, and I can tell you this for a fact, those behaviors, those actions aren't only limited to those with those identities. Mm-hmm. And so again, I go back to, it's just making sure you're linguistically appropriate when caring for a community, and not necessarily about someone with the being like something other than a human being. You know what I mean? In terms of the aspect of gender affirming care, which is one of the things that I'm fortunate enough to do at Fenway Health, I think about this in a sense as well. You're helping a human being affirm their gender. And quite naturally, the hormones that we use in some instances to help folks affirm their gender are the same hormones we use when folks are postmenopausal, when folks are born with conditions that leave their organs not functioning enough to produce adequate sex hormone levels. We use them for folks even that are assigned male at birth, as they age, and maybe they're feeling low energy or low libido, and they come in and say, "Hey, doc, can you check my testosterone?" It's the same chemicals, same medications, just applied to a different situation. And so again, this isn't an alien idea. Maybe we're using it differently, but it's the same medication and it does the same thing in the same aspects. So the same monitoring that you would do, you do it for folks that are gender expansive. So I mean, I guess at the root of me is I'm trying to push this idea that if you think back to Like before we were more equitable, folks at one point in time thought about Caucasian individuals or white individuals and people of color the same way that we try to separate folks of heterosexual identities and folks within the queer or sexual and gender minority community.
Yep.
Same thought process. We just got to get to the middle.
The other thing I wanted to ask you about, in addition to Dr. Labre's question, and then we have some questions here we'll move into. And I guess before we move on, we'll go to the first one because you referred to South Carolina. Teresa is asking, Dr. Williams, do you still feel out of sorts when you go back to, if you still do, to South Carolina? My family is from South there, and so much has changed, but so much has still stayed the same. So more on a personal level, but when you go back there, do you still feel that they have progressed?
Yeah, I still feel I feel like they have progressed, and there's still room to grow.
I say a canyon often, a canyon, not a room, but a canyon.
Very much so. I mean, I'm gonna tell you this. I'm gonna be straight up honest with you. Being who I am and the comfort that I have of myself, I'm a Leo as well, so that fire energy. Like, now when I go back, I'm just like, I know who I am, you know. So
Not
feel how you feel, I'm still gonna be the same me because I'm doing what I'm supposed to be doing, right? So, but yeah, there's still that like kind of fear of. I think my biggest fear is someone saying something to my mother and upsetting her, and then there might be problems. But
I know how that is
for me. Yeah,
there's one thing when someone says something to you, but then when you bring in a protective sort of aspect to it on behalf of somebody else, is a little different. We'll say fire, or a little different, as Dr. Labre would put it. One other question from Teresa, and I think that this is very, very important because a lot of people may not, and again, we want to get, as much from you from the medical side as well, but because you're so transparent and open about your journey and experience, taking the opportunity to, can someone speak to the pronouns, how to properly use them? And then for you, from a personal experience, what is the significance of the pronouns and why so? And for some, it may be an elementary question, but someone asked, and it would be education for all of us. And shout out to Uncle Thaddeus, who's in the room saying, great conversation, but about the pronouns.
Yeah. So the pronouns are basically a way to affirm someone's gender. Okay. That's like saying, so your name is Jimmy, but I'm going to call you Harold. That's not your name, right?
Which is my uncle, but go ahead.
Sorry, Uncle Harold.
That happened with my grandmother, but go ahead.
True. But it's about being respectful of the person that you are standing in front of or looking at or what have you. And so it's always a good practice to ask pronouns like, hey, I'm Dr. Keisha, I'm Keisha. I use pronouns they or she or he, really, for me, any pronouns as long as they're respectful. But there are some people who may prefer only they, them pronouns. They may prefer she, her pronouns. They may prefer he, him pronouns. And the reality is you can't look at somebody and ascertain what their pronouns are.
To a term that I've kind of picked up called gender presuming. Or gender assuming.
Assuming, yeah. So you have to ask. And so that is, and making that, normalizing and making it a part of conversation is going to be what helps this becomes more natural in conversation. Within the fellowship, one of the things that we worked on with the students was when you walk into a room to meet a patient. Hi, my name is Dr. So-and-so, pronouns so-and-so and so-and-so. What's your name and what pronouns do you use? Because in the world of gender expansive folks or folks of trans experience, the name on their birth certificate, the name on their license, and then the name on their insurance may not be their name.
Yep.
And that name may be the term that some folks use is a dead name because it's dead. It died when they were affirmed. Yep. But because of legal implications, they have to continue to use that name on some documentation. And so it's always a good practice to ask, what's your name? What pronouns do you use? And I'll tell you, the first time that actually happened to me, a patient asked me, a patient from the queer community actually asked me, hey, doc, what pronouns do you use? And it's so affirming to just have somebody ask and not assume. So that's what the pronouns mean. They're just as important as someone's name in affirming who they are as a human being. And so it's important to ask and not assume. You may get it correct, some incorrect sometimes.
Let me ask you this, Dr. Williams, 2 questions. I'll tell you the latter one so you can just get the thought process. But I know you're a family physician, so I know you're kind of aware of what's going on with the PD vaccine getting ready to come out. So with where you can is, much information. I know it's changing and limited. So that's going to be the second question. The first question would be, what would you say to parents who we see what's going on in Florida? We see what's going on in Texas. Yeah, same look. I could give a few looks, sip of coffee, all of that. But what is it that you would say to parents? Because I would presume that in a family practice, a parent who has a child who is going through life and figuring it out, and some will say maybe early, they don't know yet. What is it that you would say to parents whose child has come forward and said anything away from the gender of which they were assigned at birth?
The literature, the research, the data reflects that folks are aware of their gender identity as early as 3 years old. And this is reflective in the data. Now, whether or not that means that they fully feel the opposite gender, or they feel a lack of a connection with the gender that they were assigned at birth, and know that they don't fit at that end of the spectrum. Gender is not binary. It's not male or female. And so what I would say to the parent is, one, don't freak out. As folks become more comfortable being visible in the world, we are seeing that folks, there was never a binary. There was never a binary. Some cultures have caught onto this way before we started to grasp it, but there was never a binary. That's all society created. So don't freak out. The absolute worst thing that you could do for your child is to not be supportive and to not seek out resources. One, to help you understand. Two, to help them explore in a safe way, and to help you all as a family understand. I have the honor of treating young people who are exploring their gender, or who know and have affirmed through life that the sex that they were assigned at birth is not indicative of who they are. In that realm, there are families who come to see me and they have done all the research and they know folks and they're all on board and let's get this train moving. And then there are other families who are like, so-and-so just said this to us a month ago and we're still figuring it out. The fact is, you're not going to go see a physician. They're going to be like, okay, let's give them this medication and boom, bam, done. It's done. It's not like that. There's an entire process in which we help folks explore in a safe way with appropriate resources and appropriate guidance. And I, for one, if a family comes to me as a unit, I make it clear that my goal is to move with that family together as a unit. And so I would say support and education, because I've also seen the other side of that, the flip side of that coin.
Yep.
And that brings me back to the minority stress theory. Because let me see, I've got some data on this real quick. The impact that, so folks, youth in the queer community, 2 to 3 more times likely to attempt suicide.
Yep.
More likely to be homeless. They're more likely to have the latter impacts: cervical cancers, prostate cancers, diabetes, lung cancer, liver cancer. So those things happen because we're not able to access that care.
And not because can we just name, because Dr. Brandy, who comes in, and I want to talk a little bit about mental health, and then we'll get to the PD. It's not because of the decision around their gender or sexuality. And let's just name, and I was going to bring that up earlier, gender and sexuality aren't always one and the same. And I know for some folks, this is a learning curve and a lot. And I'll be honest, me as well, because you grew up Baptist, I grew up old school Pentecostal.
Oh, okay. I got you.
So let's just name that piece there, and then go maybe a little bit into, again, it's not because of their decision that they're dealing with these things. It's because of access, because they don't feel that they can access the preventative services. Because when you said things like cervical cancer and things like that, it's because, as Dr. Alabre has often talked about, and this is just in general, they don't go for the screenings and routine and preventative care because the admin there may look them up and down and whisper or be on their phone and give a smirk, or the nurse forgets and refers to them opposite of which they identify. And so we have a question coming in, but if you could finish your point, Dr. Williams, and then just maybe talk about maybe one of the resources that we know is helpful is the how do we better support our young people and parents from a psychological standpoint? Because I believe one of the resources would be, and I say this carefully, Florida, Texas, and some other places, therapy, and not, that what was that?
Conversion therapy?
Not that, but therapy in order to which, because the intersectionality of which you speak is real. Even if you excluded the LGBTQ piece. So that part, and then we'll talk about that is
one of the things we say often on this segment is healthcare matters, get it where you can. And I've been thinking this whole time, maybe this is not one of those cases where we can say get it where you can, because the difference in outcome may be greatly different. I think we're somewhat lucky in this area, at least in the greater Boston area, that there are places that do have this sort of understanding and appreciation for the complexity and the difference in sort of caring for people who may not be in the standard whatever you learned in med school type situation. And there are starting to be more and more sort of specialty clinics where you can get that type of care, and not to sort of put in a plug per se for MGH, but just recently we sort of opened up a trans clinic, and there's a lot more work to be done. It's obviously happening, which is great to see. But if you can also following up with Jenny's there, what do you say to folks out there who may not live in an area where they can access that kind of care, and how does one go about doing this?
As facilitator, let me set it up for Dr.
Thank you.
The psychological impact, or how we can better support our young people from the behavioral health, because we know that that's all part of health. So the behavioral health, the importance of behavioral health support as one of the resources. We'll do the PD piece about the vaccine at the end. And then Dr. Alabre, I just forgot that quick. Your piece was it?
Resources.
Where you go and how.
Yes. Yep. And if Dr. Kesh, if you're thinking about it while we're talking, if there's a website or number, if you put it in the private chat, I can cut and paste and make it available in the banners below.
Will do. It's exactly where I was going. So
okay.
Let me. So I'm also neurodiverse. So I gotta Run the whole gamut here.
And then we have a question on deck too. So
all right, but all right, cool. So in terms of the psychological impact, I'm gonna say this. We as people of color are rooted in this idea of resilience and strength, and we can't show weakness, because if we show weakness, then we're not good enough. If we're not good enough, we can't get to places like this and inhabit those spaces. While I am so proud of my strength and my resilience, that is not all of who I am, and that does not define me. I am human first. And just like any other human, mentally and emotionally, things affect us.
yes.
Therapy is not a bad thing. And I can acknowledge the fact that historically, as with medicine, we look at mental health spaces. They haven't always been the kindest to folks about.
That's a nice way to frame it, but thank you.
I'm trying to be nice. And we still have to move forward for ourselves. The same way folks seek out medical providers that they can identify and trust, we have to do the same thing, because we have to address the mental health within our community.
Yep.
We have to be healthy. It's part of being a healthy human being. And saying that, therapists are trained to help people navigate these journeys in a way that is safe for everyone involved. And so what I would pose to families is, before shutting things completely out, have a conversation.
Yep.
And those spaces aren't a one size fit all, and they shouldn't be a one size fit all. They should be able to meet you where you're at. And you may go into a space and it'd be the absolute worst experience you ever had in your life. And quite naturally, I know me. If I do something once, you're not gonna do it to me again. I'm just going to stray away from it. It's not the answer. It's like trying on shoes,
Or like dating.
Or like dating.
Almost like dating. Yeah.
Or like dating. Yeah, exactly. You got to press on. Use that resilience to press on for yourself and not for somebody else.
Gotcha.
In terms of the question, the resources.
Resources, yep.
So again, this goes against my mantra. I just feel like primary care spaces should be for all primary care, not just some primary care, but that's just me. We're getting there.
Yep.
But there's a list called the Out List. There's a site that I frequently provide to my patient called transhealth.org, where you're able to list a state or a zip code or a city and a search radius, and whatever healthcare service you're looking for. And it populates a list of providers in that area that have acknowledged that they are able to provide quality care. What you may experience in one place may be different in another place, but at least on that list, these are self-identified individuals who are committed to the same kind of purpose. And so at least there's a starting point. Yeah.
And the other was to look up, or they can Google the Out List.
Yeah, the Out List. Actually, the transhealth.org page there's it links at the bottom as well to that one.
Okay.
Sorry, yeah, Transcare site. Sorry, I said that wrong. .org.
Transcare.org.
Transcare site. There we go.
Okay. There we go, right there.
Thank God
technology, because we're
yes.
right here as we speak.
And then the other one.
One of the things that we're adamant about is making sure we leave with resources. And I know, these conversations, I think the more that we have them, it brings, whether you can not agree with something, but have a better level of understanding. And Quincy, and even not, and moving away from, tolerance. Quincy Roberts also often says, being where we're celebrated. And, there are so many aspects to be celebrated, being part of the community of which we are, that goes beyond identification and sexuality, but just in the resilience. And I have, Dr. Williams, I have an opinion about resilience, because we become resilient by constantly keep going through things over and over again. And, we're such a resilient community. And I'm like, yeah, that's good, but may not be so good. You know what I mean?
Mm-hmm. Yep, exactly.
This is
Exactly.
one of the I wanted to just get ready to end with a couple of questions. Thaddeus is asking, what do you advise for people that secretly sleep with both sexes to take care of themselves and their partner health wise? The person that's not telling their wife, husband, etc. Sorry on grammar, but sort of that, what we call what some quickly say DL, factor.
Yeah, I think that it starts with society, and that's reframing how we think about things. My idea is that that happens because of the negative stigma.
Yeah.
But in terms of taking care of yourself, PrEP is a thing in terms of preventing HIV, seroconversion, and so get yourself on PrEP and make sure you are protecting yourself with barriers, whatever that barrier may be, for your specific anatomy, and getting tested regularly. I know our folks that are utilizing PrEP have to see us every 3 months for at least HIV testing, but also syphilis testing.
Because PrEP
if you even have to, PrEP does not. It only protects against HIV. That is it. So you have to make sure that you're still protecting yourself from anything else that you may be at risk of coming into contact with.
Yeah.
And so, get yourself tested. And the other piece that I'll say about this, until I got to Fenway Health, this is something I was not aware of. So gonorrhea, chlamydia, and I talk about them as the same thing, but they're two different sexually transmitted infections.
Mm-hmm.
A lot of folks test genital gonorrhea, test for genital gonorrhea, chlamydia. That's with the swab, that's with urine. But folks that utilize other parts of their bodies are at risk for having infections at those parts of their bodies. And so if you participate in any type of oral interactions, or if you use your bottom for any type of sexual contact without barriers, it is important that you also swab those areas for gonorrhea and chlamydia. I have seen folks that have, a number of folks that have tested negative multiple times with the genital test. And then, I offer a swab. You use any of these parts of your body, swab, and one of them is positive. And we have no idea how long it's been positive for, nor would we have known.
This is one of the reasons that why we were specific. We've talked about men's health and women's health, and then now we're talking across the spectrum of whether you're not binary. I got you. That one. Identifying across the spectrum. We cannot let you go without tapping into the PD part of your training as being a family practitioner. We often talk about the vaccination and COVID in this space. If you could also leave us with and before we do that, we do have one that's kind of on the PD realm, and you kind of touched on this earlier, that it's not a one fits, you don't just go in and get put on conversion therapy, but not conversion therapy, I'm sorry. Wrong word. At what age is it safe health wise and as it pertains to bodily and mental development for children to undergo hormone therapy at any kind of gender assignment? Great question, Ms. T.
Got you. So in terms of the hormonal component, we don't consider youth for any type of medication for gender affirmation until they've at least reached Tanner stage 2 in pubertal development. There's 5 stages total, but at least 10 are stage 2, and that's to be able to ascertain that their internal gonads or organs are working and can produce a sex hormone.
Okay.
Because it's needed for health. It's needed for bone health. Actually, people may not know that. At that stage, depending on where you are, so for instance, for me, a patient and their family sees me. Patient also partners with one of my mental health or behavioral health colleagues, and we work together. So there's that therapy. It has to be a part of it because you got to be able to think through things. But once we as a team have affirmed that this child has gender dysphoria, I should not, a diagnosed condition,
Yeah.
then we are able to move forward. And at that point, we can use something called blockers, which we call the pause button. And what that does is prevent any further secondary sex characteristics, so like bodily changes that could mentally impact and emotionally impact that child in a negative way. We pause that pubertal development while we continue to have these discussions. And we can pull that pause button back if 3 months later they're like, hey, I'm not sure I want to do this, or pull that pause button back, when they're 17 and they're like, I'm sure I want to do this, or at 16. So there's a number of checkpoints along the way. And at no point do we actually provide cross-sex hormone therapy until we are certain, but we can pause. And that is where there's so much feeling about what's going on in Florida and Texas and saying, hey, we can't do this. Like, what you're doing is worse than what the blockers would do. You're setting this person up for multiple walls that they may hit, and things that once we finally get to an age where they can make that decision is now going to require surgery, and more medications and higher levels of medications in order to be able to be who they are. It's a conversation that's ongoing, but a lot of feelings about that, and people intervening when they don't have the education that they shouldn't, quite frankly.
I got you. And we're actually at time, but just wanted to if you could give us a little bit about where you are with the PD vaccine, and then we're going to absolutely ask you to end on, with all that you're dealing with, we got to end on how to use self-care so we can leave this space, because the space that we've integrated today has brought up some interesting points. So PD, vaccine, and then how do you self-care for yourself?
So PD vaccine, my personal feelings is we don't know. We don't have the data. We don't have the time. But what I do know is I've seen it negatively impact families getting COVID with no protection. And I've lost a friend at the beginning of this pandemic because of the internal turmoil in terms of our community's history. But what I do know is that it's worth it. I begged my sister to allow my nephew to get it, and she finally did. And so I wouldn't recommend anything that I wouldn't recommend for my own family. So that's where I am with it. Ultimately, it's your choice. I feel like it's worth it, because what I do know is without it, that factor is much worse when you're dealing with the loss of someone for something that could possibly have been prevented.
And then we know it not the same numbers with adults, but we know that we have lost pediatric patients, children, who weren't vaccinated. And so what we'll do is, Dr. Alabre, say your closing remarks, and then Dr. Williams, if you could close out with what you do for yourself for self-care.
This has been a really great conversation, and I appreciate the the resources you're providing. I wanted to actually ask one last question about access to care at Fenway Health. I know this is one of those sticky points because we want everyone to get into care, but at the same time, we're saying we're all full and no one's taking patients. Could you give us just a one-word update of where you guys are in terms of accepting taking patients?
It's much of the same everywhere. Blame the pandemic partially for that one. But yeah, we still, especially if they're youth, we'll find a way to get you in. But also,
is there like an access line that we can put a number up or?
Yeah, let me get this. I'll tell you, if you call and you ask for me, they will probably tell you my pedal is full.
The Java fam will. I had a couple of folks hit me and was like, "That doctor you had on, we've been trying to contact them directly. And we want them." And I'm like, So the general patient.
I stuck at the part. We will do our best. We will do what it takes to get you in. So
yeah, exactly. That's what it is. And I'm pulling up the contact.
Okay. And you could tell us. I can type it. We do.
Oh, okay. So it's 617. 267 0900. And they can also go to just fenwayhealth.org and should be able to register there as well.
And we may have been in the same room. Were you at the Bayard Rustin breakfast?
No, I don't think so.
Okay.
I don't think so. Yeah.
All right. There's some information here, you all, to call Fenway Health. This is not to get to Dr. Williams. This is if you want to go to Fenway Health. If you want to look up more information, don't forget we also shared this information here for you to get resources. And the out list is at the bottom of the page, to which Dr. Williams referred. But this is the general information for Fenway Health. And this is the information to get some resources, especially parents that are dealing with their children that are maybe at the beginning or anywhere on the spectrum of their gender fluidity. Dr. Williams, we went a couple of places today, and so I want to be very intentional about leaving from a space of self-care, Black joy. What is it that you do for self-care, and what brings you Black joy?
I'm still working on the self-care thing. It's been, yeah.
Hi, how you doing? We getting it all together.
Yeah, it's rough. But I will say, I'm fortunate to have patients who will remind me as I'm talking to them that I got to take care of myself too. And I'm grateful for that. But otherwise, spending time with my wife, eating, and hopefully get back into traveling soon. That's been all for now, but
that's the self-care.
Yeah.
Yes.
Yes.
I have no problem with that one. Sometimes, when these variants come up, I'm like, oh, Jesus.
Yeah.
But Dr. Williams, I definitely want to thank you, and Dr. Labra, you as well, for making sure that they were here today. But this was a very informative conversation, and sometimes we need to take and really just have these sort of conversations that bring a different level of understanding. And cadence may not be, but in all thy, you grew up Baptist, I'll refer to this, in all thy get an understanding. And at some point, I want to have a conversation from a faith perspective, because with all, and you know how we were raised, are y'all tampering? God. And it is a real, and I'm not at a point where I can say yes or no. Let's just be, honest. But I think having the conversation, because the other thing is, and we got to go. The other sometimes the therapy is sought via a religious entity that may not. So yeah. All right. Dr. Labra is about to go. And so, thank you again, Dr. Williams, for being here. We hope that we can get you back. And hopefully I'll see you toward the end of the month, because there's some, Black Pride, Urban Pride events that are going on that Cindy Diggs, where is it that she shared here? So I'll make sure that you get that information. But Dr. Labra and Dr. Williams, thank you both. We will be back on July 5th, the day after the 4th of July. Dr. Labra, did we do an assignment yet? What do we?
Hopefully we'll
we'll let you guys know what we're talking about on July 5th. But thank you all so much.
Cover a little bit as much as we can on the monkeypox situation.
Yes, that is right. That is right. And also, we may talk a little bit about the PD vax as well. And so keep that in mind. And don't forget, tomorrow we'll be back at 8 a.m. for a regular Java with Jimmy. And then at 12 noon, Mayor Wolf will be with us for her monthly appearance. And so we have a lot to discuss with her tomorrow. So thank you all for tuning in today, and we will see you tomorrow morning at 8 a.m. Thank you so much.
Bye, everyone.
Hey, everybody.